Good evening, everyone. Thank you for joining us tonight for our latest medical sciences lecture titled Women in Medicine and the Gender Pay Gap. My name is India Dean Smith, and I'm a current medicine student here at UCL and your chair for today's event. In this captivating lecture, Professor Dame Jane Dacre will delve into the topic of gender pay inequality in the medical field. We encourage active participation, so please feel free to use the Q&A function on Zoom to submit your questions for our speaker. For those following on Twitter, the official event hashtag is hashtag FMS Lectures. This lecture will be recorded, and a link to the recording will be sent out via email to all the attendees after our event. Now, before I introduce our speaker, we would like to know a little about our audience. So we're going to run a poll asking you to select the group you consider you belong to, and I'll give a minute or so for you to fill out the answers. So thank you so much to those of you that have voted. I'm now going to read out the results. So 53% of those that voted are prospective students and their families, 8% are undergraduate students, 5% are PGT students, 2% are PGR students, 2% are PhD students, 17% are academics, we've got 0% are patient and carers, and 13% are any others. And for the gender poll, 91% of the audience are women, 7% are men, 0% are trans women, trans men, non-binary, and 2% prefer not to say. So thank you very much to those that voted. I am now delighted to introduce our speaker. We have Professor Dame Jane Dacre. Dame Jane is a recognized leader in medicine. She's an emeritus professor of medical education and the former director of UCL Medical School and honorary consultant physician and rheumatologist at Whittington Health in London. She is the president of the Medical Protection Society and a specialist advisor to Parliament on the Health and Social Care Committee. She was the lead for the Department of Health and Social Care review of the Gender Pay Gap in Medicine, and she now chairs the Gender Pay Gap Implementation Advisory Group. Thank you, Jane, for joining us today. Now over to you.
Thank you very much. So there's a little bit about me there, so thank you very much. That's sort of the stuff that India has already told you about. So what I'm going to be talking about is women in medicine and the gender pay gap. So women have worked in medicine for more than 500 years. And this picture here is myself surrounded by two colleagues when I was president of the Royal College of Physicians. Now that was fairly recently. The Royal College of Physicians is 500 years old. So the fact that there have only ever been 3 female presidents of the Royal College of Physicians, and in fact 4 now, because we have another one who's just assumed office, is not a very good advert for women in medicine. So that's what I'm going to be talking about. So what I'm going to do is to give a background to women in medicine. I want to talk about gender inequality in medicine. I'm going to explain the gender pay gap and tell you a little bit about it. I'm going to talk about reducing the gender pay gap and also raising awareness of gender issues in medicine and working together to do that. And the picture there is supposed to be a glass ceiling. So the background to women in medicine is that women, as I said earlier, have been working in healthcare and in medicine for more than 500 years. But it's only around 100 years that they've been recognized as doctors. And there have been quite a number of biases against women over the years. This is a quote from an exhibition that I hosted at the Royal College of Physicians back in 2018. And this quote says, "Women as a doctor is a conceit contradictory to nature and doomed to end in disappointment to both the physician and the sick." And that was in the esteemed medical journal, The Lancet, in 1878. The quote underneath from the same exhibition says that women ought not to be encouraged to enter a profession for which they were constitutionally unfitted. That is next to a picture of the second female president of the Royal College of Physicians ever, Professor Dame Carol Black. So these views about women and women in higher education were the norm around about 100 years ago, which is pretty recent. Those views included things like women should not be allowed into higher education because it influenced negatively their reproductive ability, and also that it weakened their minds and they weren't able to do the job. Well, there were some pioneers who were determined to become women. Now, a lot of those pioneers had connections to UCL Medical School, so we're very proud of them today. And the pioneers thought that there was no reason why they shouldn't go on to become female doctors, but medical schools did not knowingly accept women. So the first women to become doctors in this country passed the exams incognito. They were written exams, so nobody knew they were women. The Society of Apothecaries, who were running the exams at that time, discovered this loophole, and they didn't go back and say, well, actually, women can become doctors. Their brains are big enough for them to become doctors. They thought this was a loophole, and they went back and closed it. But by then, some women had qualified and could work as doctors. Here are some women that were trailblazers back in the day when women were not able to become doctors, or the early career women that became doctors. So the top left on the screen is Elizabeth Garrett Anderson. She's credited by being the first woman doctor, but at the time there was so much prejudice against women being doctors that there may have been some women that qualified before her, but they kept their names quiet because it wasn't the done thing to be a woman and a doctor. The picture next door to her, Dr. James Miranda Barry, is a very interesting person who became a doctor whilst working under the name of James Barry. James Barry became the Surgeon General in the army, and it was only after she died that people realized that she was, in fact, a woman. The woman on the far right is Sophia Jex-Blake. So she and Elizabeth Garrett Anderson worked together to set up the Royal Free Hospital in London. Recent research has suggested that Sophia Jex-Blake was actually a gay woman and lived with another woman. But at the time, not only was being a doctor a bit taboo, also being a gay woman was a bit taboo at that time. The lady on the bottom left is Sheila Sherlock. She worked at the Royal Free and is known as the mother of hepatology. The woman in the middle is called Elsie Inglis. She was a female surgeon in the Crimean War, and the story about her is that she made Florence Nightingale look like a part-time care assistant by comparison. The lady on the bottom right is the first ever female president of the Royal College of Physicians, and she qualified, did her clinical training at UCH, of course, now part of UCL Medical School. So UCL Medical School has a very strong story in relation to the history of pioneering women in medicine. I first became aware of gender in medical practice back in 2009 when I was vice president of the College of Physicians. And I did a report which was called Women and Medicine, the Future, because there was concern that the number of women coming into the medical profession would actually reduce the profession's political clout. And there I am in around that time sitting amongst a group of men, because those were the people who were in charge in medicine at the time. And the two women in the top picture there are myself and Professor Dame Carol Black. If you scroll forward to more recently, when I started my work on gender pay gaps, that was published in 2020, there is me at a meeting, an international meeting, along with other Medical Royal College presidents, and there are no prizes for anybody that notices that it's not exactly boy, girl, boy, girl. So I started to look into this, and I found that there were problems with women in medicine in other areas too. There was relatively recent report done by Daphne Romney at the British Medical Association, where she said that there were examples of the Miss Triggs phenomenon. The cartoon there shows the Miss Triggs phenomenon. If you look at it, there's a group of men in a room and one woman, and the caption is, "That's an excellent suggestion, Miss Triggs. Perhaps one of the men here would like to make it." So that is much more recent. So the problems with having women and accepting women into medicine still exist in this current day. That cartoon was published in Punch. There are also problems with misogyny and sexual misconduct. There's a quote here from a paper written by a chap called Simon Fleming, and a colleague saying that surgery and surgical training have a problem with sexual harassment, sexual assault, and rape. It's an uncomfortable truth, but the truth nonetheless. And there's been some sterling work done by the Royal College of Surgeons, pioneered by Carrie Newlands and Tamsin Cummings, who run a group there addressing sexual misconduct in healthcare, particularly in surgery, and that was published last year and is called Breaking the Silence. So we have a problem. Back in 2018, I was commissioned by the then Secretary of State, Jeremy Hunt, to look at gender pay gaps in medicine. And the reason for this was because during the Junior Doctors Industrial Action in 2016, there were concerns that the imposition of the junior doctor's contract would exacerbate the gender pay gap. So I started to get interested in gender pay gaps. Now, a gender pay gap is the difference between the average hourly earnings of men and women expressed as a percentage of men's pay. This is different from equal pay for equal work. Equal pay for equal work is enshrined in the law, and that's for people doing exactly the same job. The difference with a gender pay gap is that it's a career-long difference between men and women's pay. So why is this a problem? Well, the problem is that men and women intake into medical schools has been changing over the years. In 1975, there was a Sex Discrimination Act, which meant that medical schools had to take an equal number of male and female students. And since then, the number of female students has been increasing hugely. It's leveled off at about 60% female to 40% male. NHS digital data shows us now that 45% of hospital specialists are women. All specialties have more women than 10 years ago, and 77% of NHS employees and 44% of NHS chief executives are women. Some have concerns that the women are taking over. The difference in the number, the pay of men and women, or the pay gap measurement of men and women.
Jane, I think that
yeah, it's much bigger than for other similar specialties. The gender pay gap for hospital doctors is 18.9%. For GPs, it's 15.3%. And for academics, it's 11.9%. And these are big differences. They equate to about £10,000 per year. The medical specialties are different in the way that they deal with the number of and the way that they measure their pay gap. And you can see that there are some specialties that have much bigger pay gaps than others. And the winning specialties for having a largest gender pay gap tend to be surgical specialties. The prize actually goes to urology. Generally, male-dominated specialties have bigger gender pay gaps than female-dominated specialties. This is a graph showing all of the specialties, and you can see that, in fact, there is a pay gap in every single specialty. I say every single because those where there is an adjusted pay gap in favour of women, i.e. women earn more than men, are very small specialties, and so those are likely to be experimental error. But if you look, you can see that urology has the biggest unadjusted pay gap and palliative medicine has the smallest. Urology has a large number of men in it, and palliative medicine is mainly female. This gender pay gap gets bigger as a woman ages. It actually starts as soon as women become doctors in their late 20s. It gets bigger and bigger, particularly during the time when they are having and raising children. And it only reduces when women reach the age of over 60. The contributors to this gender pay gap are complicated. And here I pay credit to my wonderful colleague, Carol Woodhams from Surrey University, who led the research that went into the gender pay gap report. They are seniority, pay scale structure, specialty, part-time working, the gender balance in the specialty, clinical excellence awards and other additional payments which are more likely to be given to men, and also the complicating factor of ethnicity. So there is inequality in medicine. Pay gaps are a metric for inequality. If you reduce inequality, you reduce the pay gaps, and if you reduce pay gaps, you reduce inequality. In fact, the structure of the NHS, not surprisingly, was set up in 1948, and that structure still exists, and that's the structure which is holding women back. And the picture here is of a household in 1948, with the woman being the housewife at home doing the work that was expected of her, not working as a doctor. So the structure of NHS pay has not kept up with the changing demographics of the NHS workforce. When we did the gender pay gap work, what we did was make a series of evidence-based recommendations. Now, these are all steeped in data. And so if we achieve these recommendations, then the gender pay gap will come down. So they are: make senior jobs accessible and attractive to women, address system barriers to the progression of women throughout their careers, increase the transparency of the pay in the medical profession, some mandatory changes, some behaviour and cultural change, clinical excellence awards, which I'll explain later. Those are bonuses for doctors, and continuing and robust analysis. And I'm going to talk a little bit more about those now. So the first is senior jobs for women. The gender pay gap is exacerbated by the number of men there are in high-paid jobs. So what we need to be doing is promoting women into senior positions. These pictures here are all pictures of women who are currently or have been in senior positions in medicine. Interestingly, a lot of them are women who have been voted into those positions rather than appointed into those positions. But they are a group of fantastic women who are trailblazing and who are moving the profession on. So they are helping to reduce the gender pay gap. There are also courses. I run a course called Emerging Women Leaders. The lady in the middle of this photograph is Lady Estelle Wolfson, who has been funding Emerging Women Leaders courses both at the College of Physicians, the College of Surgeons, who did it first, and also now at UCL Medical School. So we are running courses to support women into getting into senior roles, knowing that the more women in senior roles, the more we can reduce the pay gap. The second recommendation or the second theme for the recommendations is to address system barriers to the progression of women. And we need to recognise and address something called the motherhood penalty. Every time a woman has a child, the trajectory for her career and her pay falls off, and this isn't accounted for in pay development. We need to explore shared parental leave, which we have done, but unfortunately, a large number of males are not really interested in taking shared parental leave. So that's a cultural thing that we need to change. We need to encourage flexible working for both men and women. Men are less likely to take up flexible working because it's felt that there is a stigma related to that. An important but slightly complicated one is that we need to reduce the number of spine points in pay scales. The medical profession has a very long series of spine points, i.e. where there are increase in pay scales that goes on for many years. This means that if women come out of that or drop off that pay scale, they take a pay penalty, which takes them a long time to catch up. The current negotiations for doctors' pay have taken that into account, but sadly at the moment, the negotiations are not going very quickly, and there has been little agreement on doctors' pay with the BMA. But I reiterate that the NHS pay structures were set up with the 1948 male in mind, and we need to change that, reduce those system barriers in order to reduce the pay gap. Transparency is the next area of recommendation. Now, a large number of people keep their pay quiet. We don't know what men and women earn in our own organisation. And until we demystify pay, we're unlikely to reach pay equality. There is very little data published about men and women's pay in organisations. We also know that if there are contracts that are national, pay is much more likely to be regulated. If there are local contracts for pay, that pay is negotiated more, and men are better at negotiating pay rises than women are. So also in the spirit of transparency, we want to publish pay gaps and action plans within trusts, and publish policy for gender balance on shortlists so that we get more women into senior positions, and also publish the impact on pay for any structural changes, for example, the contract changes that are going to be happening, we hope, when there is agreement in the current industrial action. We also, in the spirit of transparency, need to talk to more women. And this is a series of podcasts that I've been developing. The link to it, or the URL to it, is below. And actually, this is a link to a series of podcasts for women who have broken through that glass ceiling, who've done well in medicine. Season 1 and 2 are women that have already reached the top. Seasons 3 and 4 are about to be produced, and they are women who've overcome barriers in their careers, and also women who are reaching the top from early success in their careers, so accessible to women who are earlier on in their careers. And I recommend them to you. There are a group of fantastic women here. I would like to also flag up that on Friday, it's International Women's Day, and I want to introduce my colleague, Professor Dame Leslie Regan, who is the Women's Health Ambassador. So her podcast is going to be released on International Women's Day by UCL Minds. So do please have a listen. International Women's Day is also Professor Dame Leslie Regan's birthday. So celebrate her birthday by listening to her podcast. The next is mandatory changes. So changes, for example, in workforce supply. A lot of the problems with the NHS these days are that we need more doctors. We need to set targets in specialties that have a smaller number of doctors and increase the number of women in some specialties, particularly in surgery. The CQC assesses how well trusts are led. We are working on the CQC to try and get them to score trusts, NHS trusts, on how low their gender pay gap is, and to put it into their well-led domain so that trusts are penalised if they are not making efforts to reduce their gender pay gap. Getting NHS organisations to be able to do these things is no mean task. We also would like to have pay gaps on trust board agendas, because unless it's talked about at trust board level, there is no incentive to get the pay gap down. Another thing that I've been working on recently is support for childcare. We would like to see, or I would like to see, mandatory support for childcare with tax relief and subsidised or indeed free nursery and after-school clubs for children to help women back to work, which will reduce the gender pay gap. There is some work being done by this wonderful woman, Sam Allen, who runs the women's network that for the NHS, and they commissioned a piece of work that suggested that we would like to see 50% of women on NHS boards by 2020. Sadly, 2020 came and went, and we didn't reach 50% of women on NHS boards, but the percentage is better. And unless you have women on NHS boards rooting for the promotion of women, we will have difficulty in getting the gender pay gap down. We need also to focus on calling out bad behaviour. There is a focus on well-being, particularly since the publication of the work on bullying and harassment. And we need to make sure that there are policies for zero tolerance when that sort of problem arises. We need to call out when poor behaviors happen. And we all need to work together to do this. The sixth area for recommendations is to review clinical excellence payments. Now, these are bonus payments that are given to doctors. They were in the past more often given to male doctors than female doctors for a number of complicated reasons. Back in 2016 and 2017, only 20% of people that received clinical excellence awards were women. With our influence, that system has been revamped and renamed. They're now called National Clinical Impact Award. There are modified assessment domains so that when doctors fill in the form for these bonuses, working in areas that are more attractive to men are assessed equally to working in areas that are more attractive to women. So that tends to be finance favors the men, education favors the women. Another inequity in clinical excellence awards that if somebody was working part-time and they received a clinical excellence award, their award or the pay would be prorated down so that they didn't receive as much as a full-time person who was getting the same award. That rule has changed because of pressure from our gender pay gap work. We are also now encouraging applications from men and women so that women are more likely to get the pay gap, pay uplift and the bonuses that they deserve. Another area is that men are more likely to negotiate pay out with bonus payments. And so we suggest that external payments to anybody in the NHS should be standardized nationally so there's less opportunity for negotiating because women do less well out of that negotiating. The last area in our themes is more robust research. This is an under-researched area, but we were able in the gender pay gap work with the support of Carol Woodhams, who's photographed here, and the Department of Health, to get huge data sets. We had over 80,000 hospital doctors and 16,000 GPs in the research. That research continues, and we're now looking at the impact of COVID. Something called intersectionality is that women get a double whammy on their pay if they happen to be from a minority ethnic group. We also want to look at ethnicity pay gaps because we think that there is likely to be an ethnicity pay gap in addition. We want to have national annual monitoring, which we're doing in the gender pay gap work that we're doing. We need to look at the promotion gap because unless we can get more women promoted to senior positions, we're not going to close the pay gap. And we also need to research the impact on pensions because if you earn less during your career, not only is your pay less, but your pension is also less. In order to do this work, we're supported by the Department of Health and Social Care, and I chair the Gender Pay Gap Implementation Panel. This is a schema of our work programme which targets a range of recommendations from the 7 themes that are highlighted and that I've just been talking about. It's designed to inspire or work partnership working, this work programme, and represents a mix of actions that will make progress and will make an impact quickly, and those that are a little bit more difficult to do, like, for example, the contract changes. Successes so far, some that I've talked about, the reform of the National Clinical Impact Award. We've had some success in negotiating reduction in spine points and shared parental leave, but we're still working on that, and that's stalled a bit with the current industrial action. And we've also had improvements to the flexible working offer to the NHS, which will roll out as the NHS People Plan rolls out. Our work programme for year 3 now has ministerial approval, And we will still be working on contract reform, cultural change, education and training about pay gaps, and data and reporting. Well, one of the things that you need to do if you want to make any change is to raise awareness. It's all very well having research which shows, in my mind, a very obvious case for reform, but getting that reform to happen is very, very difficult. Getting change to happen within the public sector is very, very difficult, and this is something that I've been focusing on. And one way of doing that is raising awareness. So I have been promoting the gender pay gap research and looking and talking about things that would reduce the gender pay gap. Unfortunately, when I first started, I got a bit nervous when I was on Radio 4. I managed to say to the whole country, only 11% of female clinical academics are women. It took me a while to realize that I'd done that, but I had the giddy heights of being in Coleman Balls in Private Eye, which I have to say has a wider reach than any academic work than I've ever done on this. I felt very embarrassed when I realized what I'd said. Another thing that we need to do in order to raise awareness of the issues is to speak truth to power. I worked hard with Jeremy Hunt when I was the president of the Royal College of Physicians. We didn't always agree, and this photograph is a picture of me looking at him. My husband says I'm looking at him like I look at my husband when he's come back from the pub after a heavy night. I'm looking very disapproving, and I've had to learn to speak truth to power in a way that power is able to listen. At the time, Game of Thrones was very popular, and this was something that was going around social media where Jeremy Hunt and I were having fights. Having said that, if you do learn, or when I did learn to speak truth to power, what was interesting was that instead of disdain, I earned respect. And it's that respect that we need to keep, the respect of people for the data, for the work that we're doing, and for moving things on. Because if we do that, we're more likely to reduce the gender pay gap. I've also been in the media in talking about how to increase productivity in this country. One of the things that was going around a few months ago was that if we got the men off the golf course, it would increase the growth of the country. So we needed to get people back into work, retired people back into work. It seemed to me that actually what we ought to be doing in the NHS is getting women back into work, and the way that we should be doing that is by offering childcare. Now, that's something that the government has now picked up, and in all of the election manifestos, we're trying to get statements in there that will support childcare to support women back into work. And we're doing that on social media, print media, and by personal contacts. But if you raise your head above the parapet, number one, don't expect to take the credit. And number two, do expect to be trolled by people who don't agree with you. However, it's more important to get this sorted out than it is to worry about those things. We're beginning to gather ahead of steam internationally, and the 2023 Prize for Economics has gone to an American woman called Claudia Goldin. Her life's work was actually about gender equality. She talks about greedy work and how the workplace sucks in men so that somebody has to look after the children because the women earn less. The onus falls on them. That needs to be addressed. She talks about a lack of workplace flexibility, which has prevented women to date from having a career and a family. But what is clear is that if the gender pay gap is going to come down, if we're going to have equality, we need to allow women to have a career and a family. Not a family, then a career, or a career, then trying to have a family, or a job and a family, but a career and family. And the key to that is affordable childcare and workplace flexibility, in addition to the gradually changing societal expectation on the caring responsibilities which fall on women. These things are all fixable, so we need to work together to fix them. This is a list of the organizations that are working together on fixing the gender pay gap in medicine. I give a shout out to all of them for working together incredibly well and very hard to try and reduce the gender pay gap. One of the recent groups that has joined and has been working with us on this is the Faculty of Medical Leadership and Management, who recognized that in their number of fellowships, there were far more men applying and getting fellowships than women, and they're working specifically on that. All of these other organizations have made an impact and are working really hard together to reduce the gender pay gap. So my last question to you all is this working? We have the data, we have the willingness to do it. We're trying to work hard with government in order to do it well. Is the gender pay gap coming down? The answer is yes. I'm grateful again to my colleague Carol Woodhams for this slide, and you can see that between 2011 and 2023, the gender pay gap is gradually coming down. In 2020, which was in the midst of COVID, the rate of reduction slowed down. Now, people ask me whether we'll ever get the gender pay gap down to zero. If you look at this graph, it is possible that the gender pay gap will come down by around 2030. If you ask a clever economist, they'll say you should never make those kinds of predictions because you don't know what's going to happen, and maybe it won't. But I'm looking at this in a half full way, and I think by 2030, we will have made significant differences to the gender pay gap. So finally, I want to stress that women are playing an increasingly important role in medicine. Because of this work, we have the opportunity to make evidence-based change, but we need to work with all sorts of different organizations to embrace a new workforce structure and culture. The medical workforce needs its men and its women. It needs everybody to work together. And doing that, the gender pay gap is reducing. And during the time that I've been doing this work, people often ask me why I'm such a feminist. And I like to think of this quote from the artist Rebecca West. What it says is, I've never been able to find out precisely what feminism is. I only know that people call me a feminist whenever I express sentiments that differentiate me from a doormat. What I say to the 90% of women in the audience is, don't be a doormat, your future is bright. What I say to the 10% of men is, don't treat your women as if they're a doormat in relation to their medical careers. So maybe I am a feminist. Thank you very much.
Thank you, Jane. That was great. That was a really fascinating lecture. And now we're going to move on to our Q&A. So for those of you watching at home, if you click on the question and answer tab, you'll be able to submit your questions. And whilst we're just waiting for those to come through, we've had some questions before the webinar already submitted. So the first question we have is, would you recommend the profession of medicine to other people like your children, for example?
So I have 3 children. None of them are doctors, but it wasn't anything to do with me, or at least it wasn't that I didn't recommend it to them. I think being a doctor is a fabulous career. I think that it works well with being a woman. You have to be smart to be able to make it work well for you. You have to be flexible, but it fits well with women's desire to care for people. And for those women that have a scientific background and want to care for people, I think it is an absolute privilege to be a doctor. So yes, I would recommend it to my children, and I'm a bit sad that none of them followed in my footsteps.
Great, thank you. And our next question is, what is the biggest challenge you have overcome in your career as a woman?
I think it has been the balance of career and family, just as Claudia Goldin says, that I have been fortunate to have a very supportive family, but sometimes it's extremely difficult to manage, for example, doing on calls, rotating around the country with having a family, having small children at home. Childcare is ridiculously expensive, which is why I'm so passionate about working on that at the moment. So I think that is the biggest and probably an unspoken challenge that I think all women ought to speak up about so that we can make sure that it's fixed in order to bring the gender pay gap and the inequality down.
Great. So our next question is, why do you think that men are better at negotiating pay rises than women?
I think they're more interested in money. I don't know why. And so they're keener to say, so if you offer a job to a woman, society's pressure on women would say that a woman says, I'm really grateful that you've offered me that job. Thank you very much. I'm so honored. If you offer the same job to a man, the tendency is for the man to say, how much? Men Are from Mars and Women Are from Venus is a book that perhaps people should read.
Okay, great. Thank you. And our next question is there still in our 21st century a gender pay gap?
Yes, sadly, yes. And it's surprising, but it isn't surprising because a lot of it is structural. A lot of it is to do with, as I've been saying, women not reaching the top of their profession.
And our next question is, do you have any advice for aspiring women medics?
Stick at it. Medicine is a wonderful career, and it is an absolute privilege to go into medical school. Now, there's a lot of churn at the moment, and there are a lot of people that are unhappy. I still think it's worth it. I still think it's a wonderful career. So, if you work hard, if you're good at science, if you like people, then it's definitely something you should do. Practice to make sure you can get your science A levels. If you're not, if that doesn't come easily to you, you're more likely to struggle in a medical school setting. I think probably being at medical school is harder than being a doctor. So if you can get through that, the world's your oyster.
Great, thank you. And our next question is, how does the gender pay gap in medicine compare to other professions?
It's worse. The gender pay gap in professions like, for example, the civil service is down at around 6%, 7%. So the gender pay gap in medicine at about between 15 and 18% from the data that I've shown is worse than other professional groups. It's not quite as bad as the financial sector, and it's not quite as bad as the airline industry. And the reason for that is that it's very obvious in those sectors there are men at the top earning high salaries and women at the bottom not being promoted and earning quite a lot less.
Okay, interesting, thank you. And our next question is, why is getting into medical school so competitive if the NHS needs more doctors?
I know the number of places, medical school places, is capped by the government for financial reasons. And so there are not that many medical school places, but because of campaigns by the Royal College of Physicians and others, the Department of Health have agreed to double the number of medical school places. So there is a process going on at the moment to increase the number of medical school places to try and help more of those people who are perfectly able to become doctors to get into medical school. It's a silly thing which needs to be fixed and is in the process of being fixed. I was reassured only last week by the Department of Health.
Great, thank you. And our next question is from Carol Woodhams. So Carol says, thank you, Jane. I have been honoured to have a front row seat to observe all these changes that have assisted in coordinating reduction in the gap and so many name checks in your presentation. We've done a lot via the implementation group, but what is your current top priority that will have the most effect?
So this is maybe a bit political, thank you, Carol, and that is to reduce the number of spine points. So slightly technical, but when the negotiations with the BMA were going on in relation to the consultant doctors' pay deal, reducing the number of spine points was one of the negotiating points. If that had been accepted, it would have made a sea change in reducing the gender pay gap. Unfortunately, the consultant body narrowly voted against it. I say unfortunately because I'm a one-trick pony only thinking about the gender pay gap. I'm sure they had very good reasons. So I would say my priority is to get people back to the negotiating table and to give gender pay gaps more airtime and for people to understand more how important it is to reduce the gender pay gap, because the majority of doctors are likely to be women in the future.
Great, thank you. And our next question is, what happens if the measures taken to reduce the gender pay gap has a negative effect and the men start getting paid less than women?
Well, I think it's going to be a long time before that happens. I think the best we can achieve is equality for men and women's pay. For 500 years, women have been subservient to men, both in society and also recently in terms of pay. I don't think that's going to change anytime soon, so I wouldn't worry.
Okay. And our next question is the pay gap still as prevalent as for women who choose not to have children?
Yes, it's not as bad, but it still exists. So there are pay gaps for women who choose not to take time out and who aren't affected by the motherhood penalty, but those women are still affected by the gender pay gap.
Okay. And our next question is, what can be done day to day clinically to combat the gender pay gap?
So our 7 areas are areas that I think are everybody's business. So I think perhaps most easily for those that are working at the clinical coalface, one of the things that we ought to do is to talk about it more. And to make sure that our employing organisations are aware of the gender pay gap, to ask male colleagues how much they earn, and to call out to trust boards and trust managers when we see inequality, for example, in gender pay gaps. So that's what the individual person can do. For any men in the audience, please be our allies. It's better for everybody if we have equality at work. It's better for patient safety, it's better for the workforce, and it's better for productivity.
Great. And our next question is, what do you think was the biggest thing that reduced the gender pay gap?
It's very hard to tell what are the contributing factors. But the when Carol did the original analysis, which was extremely complicated statistical analysis, the biggest causes appeared to be the number of men in very senior positions still in medicine who are at the top of the pay scale. So I would say gender balance at the top of particular specialties, especially surgical specialties. And I would say the pay structures, so allowing there to be a very long series of spine points, which allows men to come in at work, carry on doing nothing particular, but just staying there and ending up on very large salaries. So those review of spine points, I think, would make the biggest transformational change.
Okay. So our next question is, at times I have found it difficult to differentiate when I am being undermined in research because of my gender or lack of seniority when working in a very heavily male-dominated research team. Do you have any advice for dealing with this?
I suspect it's both, and I think it's very difficult. I would suggest that it sounds as if you are an individual, and I would have thought it's worthwhile getting yourself a mentor or a coach that is a colleague that you can talk to about those things and that you can practice strategies. I think it's very common for women to be undermined when they are in a minority and when they're in a male-dominated environment, and it's very difficult to tackle as an individual. So you need friends, you need a mentor, you need allies to be able to address these things. You can't do it on your own.
Great, thank you. And our next comment is, as a trainee doctor, how can awareness regarding the gender pay gap be raised locally at our NHS trusts?
So one of the things that is interesting about NHS trust boards is that they are meetings that are held in public. So anybody on an NHS board can go and listen to what the board is discussing. So if you get the agendas of that board, you can turn up and at some stage during the meeting, you're able to ask questions. But the other thing is just to ask your medical director or the clinical directors what the gender pay gap is and get them to go away and find out what it is. Unfortunately, in trusts, they usually look at the gender pay gap in the round. The area with the biggest gender pay gap is actually the medical profession, and it's much harder to get them to separate that out. So that would need to be a conversation with the medical director.
Okay, great, thank you. And our next question is, what can we, students, do to help and be involved?
Well, I would love you to be involved. I think raising awareness is far more important than people give credit for. It's all very well to have a lot of fantastic research and data that shows that something definitely should be done about a particular area. But actually, implementation is really, really difficult. And one of the things that we need to do to support implementation is to get everybody talking about it. So if everybody, including students, understand what a gender pay gap is, talk about it within the professional groups that have bigger gaps, then we have a better opportunity for everybody to understand the issues, what the potential consequences are, and to start to bring the pay gaps down, which means reducing inequality.
Great, thank you. And our next question is, what is the pay gap between men and women of colour?
So that's complicated because there are, you saw at the beginning of the lecture that we have a number of genders now. There are even more minority ethnic groups, and so the dividing up and the work to do on ethnicity pay gaps is much more difficult. We have been urging the Department of Health and the NHS to look at ethnicity pay gaps. At the moment, I don't know, I don't have a figure for it, an overall figure for it, because that we haven't reached that level of granularity in the research.
Okay, thank you. And next we have you faced discrimination during your position as one of the only female presidents of the Royal College of Physicians?
Have a look on Twitter. Have I faced discrimination? Yes, not overtly. What happens is that the comments and the discrimination gets driven underground. But certainly during my career, I've had inappropriate things said and done to me, and I think all women have. And I have also felt that I've reached the glass ceiling, sometimes in my own organization, and that I haven't been promoted. Now, would I call that discrimination? Maybe I wasn't good enough. It's very hard to point the finger and say you've been discriminated against, but there are certain biases that I think all women have encountered during their careers that have been barriers to their career progression.
Thank you. And our next question is, what opinion should medical students have on gender pay gaps in interviews by medical universities?
Well, I think they should say that they've looked into it and they're very pleased that work's being done and it's coming down.
Great. And our next question is, does the gender pay gap differ across different areas of the UK?
We did some work on geography, and strangely, it was better in London. I think that's just because the opportunities are greater in London, but there isn't a big geographical spread.
Okay. And similar to that question, are other countries doing better in reducing the medical gender pay gap? And what could the UK implement from them if so?
Well, the countries that have lower gender pay gaps tend to be the countries like Sweden, Norway, where they have better equality for women. I think the country with the largest gender pay gap, the last time I looked, was South Korea. And so it's countries where they focus on equality for females, where they tend to have lower pay gaps and pay structures that pay women more equally than others. I mean, there used to be a rule that when you got married, you had to give up work. So things are a lot better than they were. But we still haven't reached equality, and those countries that are further ahead in terms of reaching equality have better gender pay gap data.
Okay, thank you. And our question here from Rosie Harborne: do more women work in alternative therapies than men?
I suspect so. So on that graph where we showed the raw gender pay gap against the professions, one of the negative bars was complementary therapies, and I suspect that's because more women work in complementary therapies than men, but I don't have the data. Not all complementary therapies are regulated professions, so it's difficult to get the metrics. I mean, one of the things that was so helpful about the work that the research that Carol did was we had access to the NHS electronic staff record. So that's the database that employs all staff. So if you're not in that database, it's harder to get the data. So it's harder to be sure about the numbers.
Okay, great, thank you. And our next question is, any advice on encouraging deaneries to allow quicker training progression for less than full-time doctors?
I would love that to happen. And I think that the NHS Workforce Training and Education, what is it called? Directorate. Health Education England has changed its name to NHS Workforce Training and Education. And I think that they would do well to focus on the achievement of competencies rather than time served in training, to allow people to fast track through training if they demonstrated those competencies. That was one of our recommendations. And that would mean that you could go through training more quickly, and that would definitely help the women. I was a commissioner on the Times Health Commission, and one of the things that we discussed there was shortening the time for medical training. That's a bit controversial because there's a lot of discussion about physician associates and having shortened training and achieving competencies. So it would need to be thought through rather carefully.
Great. Well, thank you very much, and thank you to all of you who submitted questions. It looks like we're out of time and we'll need to conclude here, but thank you everybody for joining us today. Before you go, we kindly request your feedback on today's session. A survey will be sent to you shortly after the event, and we greatly appreciate your input. So many thanks to everybody who shared their comments, and a special thank you to Professor Jane Dacre for delivering an excellent lecture. Wishing you all a wonderful evening.
Thank you.
Thank you.